All right, welcome everybody. It's a really nice Saturday night, and thank you everybody for attending our online webinar. And I'm your host. My name is Ife, and very nice to meet all of you guys on a weekend. So I want to give a very brief introduction about our organization. So this is the International IVF Alliance. And we do have LinkedIn and a Facebook page for everybody to look at. And then I want to thank my three nice colleagues, and Wei Zhang, and she is an app manager of Reproductive Partners Fertility Center in San Diego, and also Dr. Yu and Dr. Li. They both are helping me run this program, and a lot of thanks to them. And then, so today's speaker is Dr. Megan Dofton. And then I also want to give a brief introduction. And Megan and I go way back. We were colleagues at Yale for about 2 years, right?
That's right.
So, yep. So Dr. Dofton has been in the field for more than 20 years. And then she started her undergrad research in Acadia University. And then she moved to UK and working on the embryo microsurgery at the University College of London. And she returned back to Canada and started her PhD at Dalhousie University. Am I pronouncing the name
That's
correct?
right, yeah.
Okay. All right. So her major was developmental biology, and building upon her previous experience in embryo microsurgery, protein and DNA analysis, and also histological technologies. And then she became a PGT coordinator and at Atlantic Fertility, and during her postdoc fellowship. So she oversees the PGT program of 2 places, and then she became an embryologist. Now is the lab director of AART, or now is Atlantic Fertility.
That's right.
Okay, I still remember.
Just names. Just changed.
Yeah, all right. Thank you so much, Megan, for sharing your expertise. And I know you're super good at the embryology and andrology, but today you're going to share your experience with us, is how to prepare sperm for conventional insemination.
All right.
All right.
Share my screen here. Give me permission, Ife.
Oh, sure. Sorry about that. Let me
That's all right.
Sometimes the Zoom get me really confused about where to click. Huh. Why it's not?
There we go.
Yeah.
I think I got it.
All right. Thanks.
All right. Thank you. All right. Well, thank you for the opportunity to speak tonight. As Ife said, we go back quite a bit when Ife was a new embryologist, and I thought I was slightly experienced with 2 years of experience. But what I'm talking about tonight is some expertise that I brought to Yale with me when I went there, and then kind of back at my original clinic where I learned it all. It's something that doesn't really get focused on a lot, so I thought it would be nice to kind of talk about it tonight. So I'm mainly going to focus on sperm hyperactivation and its assessment for clinical use. So I'm going to jump right into the agenda. So we're going to talk about what is sperm hyperactivation for those who aren't overly familiar with it. And why does it matter? Why do we care about sperm hyperactivation? What role does it have? Is it important IVF or ICSI or conventional insemination ICSI? Role it may play in failed fertilization and analyzing failed fertilization in your clinic. I'm going to talk about how we measure hyperactivation and how once we have this data and this measurement, how can we apply that clinically? And then finally, I'm going to talk about how we use hyperactivation to do some research projects to overcome a clinical deficit. So firstly, what is hyperactivation? Hyperactivation is sperm motility characterized by asymmetrical flagellum beating. Has increased velocity and a very large amplitude of lateral head displacement. So a head motion moving side to side, and is often asymmetric flagellar movements with very vigorous side to side movements. So some people describe it as a whip-like motion that you might see with the tail that starts just behind the mid-piece with an undulation, bending the head left or right, and then it's propagated down through the flagella. So if you look at picture B here, that is hyperactivated motility. If you look at their sperm tracks, you can see they're very irregular, all over the place. Whereas with regular sperm motility, the beating of the flagellum results typically a very straight line, smooth pattern in picture A. So if we look at these images down below, what we can see is any sperm tracks that are highlighted in pink are a hyperactivated sperm, while any sperm tracks identified in orange are just a progressive motility. So you can even really see identified in these images the more irregular and whip pattern that has moved the sperm with pink versus the more straight line pattern of the orange. So why do we care about hyperactivation? So in order for ejaculated spermatozoa to be capable of fertilization, they must undergo a few maturation steps, all part of capacitation. So capacitation involves biochemical and physiological modifications to the sperm to prepare them to penetrate the zona pellucida in an egg. So capacitation requires two steps. First, change in the sperm head loses proteins and cholesterols from the plasma membrane, which is required prior to acrosome reaction. So that is one important part of capacitation, but obviously not the focus for tonight. Number two is what we're interested in, which is hyperactivation. And again, it's that change in that swimming behavior. So we know that typically in vivo, capacitation occurs within the female reproductive tract when the sperm cells are separated from seminal plasma. And in vitro, of course, we need to do this physical removing of the sperm cells from the seminal plasma in order to achieve hyperactivation. And as I've already mentioned, hyperactivated motility is required for sperm to penetrate the zona pellucida and fertilize the oocyte. So obviously, hyperactivation is a key requirement for conventional IVF insemination. Without hyperactivation, there won't be any fertilization. Obviously, when using ICSI, we override this requirement. So this brings me to conventional insemination, or ICSI. As we know, our field is largely moving towards ICSI for all approach. We see it lots of time. The majority of clinics, the more cycles we're doing frozen eggs with PGT, some cycles for advanced maternal age, some cycles have low oocyte yield. It's very common. We're becoming very, very comfortable with using ICSI for everyone. But in this talk today, hopefully I'm going to convince you that conventional insemination is still a worthwhile procedure for a specific population of our patients. So this is just a few examples of more recent literature that's published to show us that the recommendation is in the absence of male factor infertility, we should use conventional insemination when possible. So ESHRE guidelines, ASRM guidelines would indicate this as well. And that is really because if we look at this little blurb here, what we find is in the absence of male factor infertility, if we use ICSI, we actually typically will have inferior live birth rates. There's an increased cost to our patients, an increased time in the lab, training, quality management. And there's just not really a role that necessarily says we need ICSI for these patients. There has been A lot of theory that using ICSI overrides natural selection of the sperm that happens in conventional insemination, and also that there's evidence that us breaking through the zona pellucida and injecting the eggs may result in a different epigenetic signature than those that were fertilized through conventional insemination. So obviously, we all want to do the best for our patients. We want to give them the best chances of the highest pregnancy rate and highest cumulative live birth rate while being minimally invasive. But of course, what we're all scared of is the dreaded failed fertilization. Because of course, with that is a consequence of financial and emotional loss for our patients. So I think largely our field has switched to ICSI for non-male factor cases for some of the other reasons mentioned, but also that fear of failed fertilization. A little more recent study. So this one just was published in April in Nature. It's just one last piece of evidence that really strongly shows that in couples without severe male factor infertility, if they're randomized to conventional insemination, IVF, or ICSI, what they found was that the cumulative live birth rate was actually higher when they used conventional IVF insemination. And if you look on the bottom of the slide here, the fertilization rate per egg retrieved was significantly higher in the conventional IVF insemination group. So this study concluded to say, if we're going to do gold standard IVF treatment with couples that do not have severe male factor infertility, ICSI provides no benefit. And in fact, it may hinder treatment in some ways. So we need to be comfortable with the fact that conventional insemination done well is both most gentle on the eggs and sperm, cost effective for our patients, and resource efficient for IVF clinics. So we should really prioritize a minimally invasive treatment. But as I said, we're all scared about the dreaded failed fertilization. This study looked at failed fertilization across IVF in ICSI cycles, 6,000 of them, so it's quite a large study. Usually in the literature, we see that the incidence of complete failed fertilization is quoted to be about 5 to 10% risk for conventional insemination, while only 2 to 3% risk following ICSI. This study is one of the largest studies comparing the two, and it actually shows that the risk across all cases is about 4.2% for failed fertilization, regardless of fertilization mode. And what they actually found was that failed fertilization incidence was 4% with conventional insemination and 4.5% with ICSI. So they actually demonstrated that if you look at a large sample size with appropriate patient selection, failed fertilization rate is lower using conventional insemination. Now I'm going to talk a little bit about our internal stats at Atlantic Infertility. When we use a hyperactivation analysis in conjunction with our basic semen analysis. So this data is a little bit dated, but it remains pretty consistent across our clinic. So in comparing fertilization rates for conventional insemination, we have 830 cases. 1.9% had what we considered low fertilization rate, which is 3 or fewer zygotes, and 1.7% failed fertilization. Whereas with our ICSI cases, we had a low fertilization rate of 3% and a failed fertilization rate of 2.4%. So by using really tight parameters on patient selection for conventional insemination, we have a much lower failed fertilization rate for conventional insemination than ICSI. So our key, I think, a main component of our recipe is our hyperactivation assay. So if we can do a hyperactivation assay, we have to know how we can measure hyperactivation. So sperm hyperactivation is determined by analyzing sperm kinematics, which can be a particularly tricky area of our field, but just in general, sperm kinematics is the mathematics of sperm motion. And we can break it down into a number of different definitions of things we're looking at. The easiest way I find to think about it is that there's types of velocity. There's curvilinear velocity, or VCL, straight line velocity, VSL, and average path velocity, VAP. So VCL, or curvilinear velocity, is the total distance that the sperm head covers in a given observation and is typically the highest value. So the total distance covered by the sperm head. VSL, the straight line distance between the first and the last points of trajectory, giving a net space gain. So it's usually the lowest value because it's a direct line between start and end. And then finally, VAP, the distance of the sperm has traveled in an average direction or motion. Then the next measurements of sperm motion is ratios of the velocities. So linearity, straightness, and wobble. And then one of the most important ones for analyzing sperm hyperactivation is lateral head displacement. So the width of the lateral head movement of the sperm. So as I was describing previously when talking about sperm hyperactivation, we're looking for that very distinct head bend or nod or wobble, whatever we want to call it, from the midline structure. So that is one very important part of analyzing sperm hyperactivation. But a number of these measurements are used to really look at whether a sperm is hyperactivated or not. So how do we actually physically measure them? It can be done manually, which was the traditional way, which requires extensive training and QC, and is obviously very time consuming to manually analyze samples. Now, I know this is past sperm experts, PhDs doing this sort of thing. I don't know anyone currently who can measure hyperactivation by eye and has maintained the skill over time, because really it has been replaced by computer-assisted semen analysis, or CASA systems. CASA systems are very quick and they can easily identify the percentage of hyperactivated sperm in a given sample. There are a number of different CASA systems that can measure hyperactivation. However, I am most familiar with the Hamilton-Thorne IVOS, which is what we've used in our clinic for many years. So that's what I'm going to focus on this evening. So we used to use the IVOS 1. So you'll see some images from IVOS 1 and some from IVOS 2. An important feature is to always know how many hertz frame rates they collect at, because it needs to be a sufficient hertz. And then the requirements built into the algorithms of the IVOS to determine hyperactivation. So in the IVOS by Hamilton-Thorne, there is a add-on feature called sort that needs to be purchased in addition to the equipment to analyze hyperactivation. In the IVOS 1, which is a dinosaur, we're using a very old one until about 2 years ago. I don't know that there are many out there left for clinical use, but I'll tell you how it was set previously. So it had a VCL of greater than 150 microns per second, and linearity less than 50%, and a lateral head amplitude of greater than 7.0 microns. So again, moving quickly, but not in a linear way, with a high amplitude of head movement. The IVOS 2, the pattern is a bit more tricky to understand. So it looks at track speed, again, 150 microns per second. And then it uses a different calculation called fractional dimension D, and that's greater than 1.2. And D is a quantitative assessment of space filling properties on the curve. So again, an analysis of how much space or bend that head is making through the track. One important factor is to always remember, if you are using a CASA system to analyze sperm hyperactivation, the chamber depth needs to be deeper. So it needs to be at least 20 microns deep. We use the Leja slides. And that's because, of course, with hyperactivated sperm, we have that whip-like tail motion, and there needs to be enough space to allow for a proper hyperactivated corkscrew whip motion of the sperm tail. This is an image from the IVOS 1, so you'll see both of these tonight, but the IVOS 1 wasn't quite as advanced, so of course you can see it doesn't kindly color code things for us like the IVOS 2 does. So here is some of the output from the IVOS 2. Again, it color codes the sperm for us, pink for hyperactivated, orange for progressively motile. And then if we looked in the zoomed in image on the right, you can actually click on each one of these sperm samples and view its track pattern at each frame that was captured. So you can see really the extreme kind of head whip back and forth of this sperm pathway. And it's pink again, indicating that it's hyperactivated. But when we ask the IVOS to tally this all up for us, this is the kind of table it gives us. So in our clinic, we always analyze at least 1,000 rapidly progressive cells in order to get an accurate kind of general impression of the sample. And we do 2 replicates and average them. So we're looking at least 2,000 cells. And what we can see here is that in this sample, there were 44 hyperactivated cells, which resulted in a percentage of 3.3% of the sample being hyperactivated, which is actually quite a small percentage. All right. So now that we know how we measure it, how do we know how to accurately measure it for clinical use? So the first thing we need to consider is spontaneous hyperactivation. So the natural amounts or percentages of hyperactivation in a semen sample. So, in a wash semen sample. So this study looked at 25 different individual semen samples and how hyperactivation spontaneously occurred over time and in between and compared between individuals. And so what was determined was that hyperactivation is quite transient and highly variable. So it changes from time point to time point, both within an individual and in between individuals. And it made it very difficult to determine one kind of spontaneous time to assess this at, to give an overall example of what, or picture of what the spontaneous hyperactivation might look like for this patient. So in order to overcome this, there has been a hyperactivation assay developed to compare the spontaneous hyperactivation with an induced maximal hyperactivation, so HA max. So because I mentioned the spontaneous is so variable and not reliable, we can use this HA max assay to capture the maximal capacity of a sample to hyperactivate. So kind of giving the sample its best opportunity to perform, and then using that number, we can kind of gather what the capacity of that sample is overall. So after we use a density gradient to process the sample and remove all seminal plasma, the sample is exposed to the hyperactivation agonist, which contains progesterone and pentoxyphylline. So we call this an HA max solution. It has 1 microgram per mil progesterone, 3.6 pentoxyphylline, in culture media containing 30 milligrams per mil human serum albumin. And the HA max reading is read 1 hour after exposure to the agonist. So just a little bit more in depth, just a reminder for the assay that the cells must be separated from seminal plasma, ideally using gradients. They should be washed in a bicarb buffered media that supports capacitation. After the sample is processed, you're going to do the sample into 2 halves. 1 half is going to be mixed 50-50 with the HA max solution, which is prepared fresh each morning. Once it's mixed 50-50 with the HA max solution, it's gassed and placed in the incubator for 1 hour. The remaining half of the sample is your control. It's mixed 50-50 with culture media and incubated again for 1 hour to give us our spontaneous amount. All right, so after 1 hour of incubation, we read the samples on the IVOS again. measuring a minimum of 1,000 motile cells, and we do this in 2 replicates. So we can see in our first table here, this was our control tube. It measured 345 hyperactivated cells, which resulted in a percentage of 29.3 overall. And then our HA max sample had 847 hyperactivated cells for a percentage of 63.5%, which is obviously significantly higher for the patient. So this takes me to how do we use these values now that we have them? So these values were suggested as a practical guideline in the Bourne Hall Practical Basic Andrology based on studies, internal studies they did. So this is the cutoffs we use in our clinic. So a sample is considered normal if it has a control percentage of hyperactivation greater than 20% and an HA max greater than 50%. So a couple with a sample like this, we would consider appropriate for all treatment. A good sample is greater than 20% control and greater than 20% HA max. For this couple, they could still consider intercourse, IUI, or conventional IVF insemination. A low quality sample is less than 20% control, less than 20% HA max. For this couple, we would recommend no more than 3 IUIs. If those are unsuccessful, move directly to ICSI. And also an abnormal sample would be less than 20% control, less than 10% HA max, or if the sample is divergent between the two, greater than 20 to 30%, we would always recommend ICSI for these patients as well. So here is our sample output from an example patient, and you can see that their control is 28% and their hyperactivated HA max is 65%. So for this couple, good news, they have an option of all treatment. Whereas this poor patient, unfortunately, had a spontaneous of 7% and HA max of 5%. So this couple we would recommend directly to ICSI. So these are the cutoffs that we use in our lab for clinical use. There is not a lot of data available on these. So some other studies, so it was done in 2001. They didn't set strict cutoffs, but they looked at if there were characteristic differences in hyperactivation in good versus poor fertilization groups using conventional insemination. And what they noticed were some pretty strict cutoffs in differences in linearity, ALH. So again, looking at average velocity pathways, pathway head bend, and how the straightness of a pathway. These were important key factors to the success rates of of fertilization rates. This other study, they were interested in looking at fragmentation, hyperactivation, and hyaluronic binding. But what they did was they also used the HA max, and they looked at how fertilization rates were with different induced or HA max percentage of hyperactivation. And what they found was that they are correlated. So the better hyperactivation you have, the better fertilization rates. And if you look down here, they did find that higher percentages of, or the percentage of hyperactivation was significantly impacted the fertilization rate with using conventional insemination. And no surprise, did not affect the fertilization rates when ICSI was used. So everyone kind of sets their own cutoff, but we've been using our cutoffs in our clinic for about 10 to 15 years now. But of course, that's not the only thing we look at. We're not just interested in hyperactivation in our clinic. We do an extensive semen analysis to determine which pathway patients are going to go, IVF or ICSI. So this is an example of the semen analysis output that we do for each one of our patients that do semen analysis. So it starts with the basic, as you would expect, where the sample is produced, um, appearance, liquefaction, how it was collected, mucoid particles, viscosity, days of abstinence, odor. And again, the typical things we look at, the volume, the concentration, total sperm count, percentage of clumping, what the clumps look like, whether they're aggregate or they're specific, like tail, tail, head, head. We calculate the total motility for the sample. We look at the debris, the number of round cells present, epithelial cells, red blood cells. If there are round cells present, we will run a hydrogen peroxidase leukocyte screening test just to determine if leukocytes are present. And if leukocytes are present over 1 million per mil, we do send them to ICSI. We look at pH. We also run anti-sperm antibody analysis for all of our semen analysis patients. And of course, semen analysis is required for all of our couples that are considering IVF insemination. I mean, typically we don't get any surprises with anti-sperm antibodies. Rare, sometimes we do, but the vast majority of patients that do come up with anti-sperm antibodies are vasectomy reversals, and often they do have very good samples, with the only trouble being head-bound anti-sperm antibodies. Then, of course, we're looking at motility of the raw sample. So we count motility to 4 categories: rapid, slow, non-progressive, and immotile. We do this by hand, manually. So we do a lot of training and QC for this on at all times in our clinic. If the motility is low, we will run vitality stain. And then we use Pap stain or DiffQuick to look at morphology, and we do use a strict morphology. We do look at total normal forms, although largely in our clinic, we do use Tradazoo-Spermia index. We take that one more seriously. So that, of course, is the average number of defects per sperm. And we have a strict cutoff for that as well. One other thing we look at that's a little bit out of sort of the norm for my morphology is acrosome defect. So we had seen in a history of patients that otherwise everything looks good, but had a very high number of acrosome defects when we went back after a low fertilization result, and found that there was very high number of acrosome defects, obviously resulting in poor fertilization. So that is something we do note now is even if the TZI is low, is there a lot of acrosome defect present? The next thing we do is a trial wash. So we do a trial wash for all of our patients doing semen analysis. Typically we use density gradient, although if it's a poor sample, we might do a simple wash, or depending on the mode of treatment, we might do Zymot. We record here the volume that went on the gradient, the final volume was reconstituted in, the concentration, total progressive sperm. We look at recovery to see if there's any indication for any abnormalities in the percent recovered, the theoretical yield. And then the last thing we look at is, again, motility to 4 categories. This portion is counted using the IVOS, so we don't do wash samples by hand. We do raw samples by hand just because of the history of difficulties of IVOS reading accurately raw samples, where it's much more accurate with a wash sample with debris removed. We prefer to see a rapid progressive of 70 and an overall progressive motility of 85% for conventional insemination. And then the very last thing down at the bottom is our hyperactivation assay. And this is a line from our poor patient that I showed you earlier that we would indicate straight to ICSI for. So you can see our note down at the bottom, poor wash motility and recovery with borderline rapid progressive, so recommend, and low HA max, we recommend ICSI for this couple. All right, so the last thing we consider with hyperactivation is on treatment day. If we run the sample as we did for our sample wash on SA day, and everything performs the same, our last check is then to look at spontaneous hyperactivation at the time of running the sample. If it's less than 10% right after processing on treatment day, we will recommend ICSI as well. So by following this very strict criteria and selecting patient population very carefully, we are able to have that very low failed fertilization rate with conventional insemination. And you might be thinking now, well, how do they have any patients that pass all these things? And you would actually be surprised. We do a large proportion of conventional insemination, somewhere around 40% of our cases typically meet criteria for sperm samples that can go ahead with this. Again, just a reminder that, doing this extensive workup to choose the appropriate patients for conventional insemination helps to lead to these low failed fertilization rates and no surprises. So again, this is just showing us, using CASA, there is a very direct link between hyperactivated motility and good fertilization rates. All right, so that's kind of the clinical portion of my talk about how we apply it in our clinic. The next portion is talking about how we've used hyperactivation in our clinic to tackle some research problems that have helped shape clinical care. So I'm going to talk a little bit about microfluidic sperm sorting that many of you probably are familiar with. We got really interested in it when we first started seeing the first publications and really started looking into if this is a good option for us. The initial studies were showing that these samples processed using microfluidic sperm sorting had good concentration, motility, and morphology. And a lot of the early studies were showing a really great reduction in the amount of DNA fragmentation in the processed samples. And they were showing really great stats when used with ICSI. However, when we dug into it deeper, as such a large portion of our patient population used conventional insemination, we were finding that it was not recommended for this. And when we contacted the company to find out more, we actually found out that it was because there had been some issues using it with conventional insemination, such as failed and low fertilization. But in our clinic, we really wanted to look at, well, what is going on here? Why can't we use it for our conventional patients? And can we figure out a way that we can make it work? So I'm just going to go back step a little bit and talk about traditional density gradient centrifugation. We know that this has been kind of the gold standard in our field for many, many years. And using density gradients facilitates the separating of sperm cells from seminal plasma, debris, round cells, abnormal and immature sperm cells, and of course removes the decapacitating factors from the sperm cells from the seminal plasma. It works really well, selecting motile cells with normal morphology typically. However, we do know that there are definitely some downsides of using density gradient centrifugation, being the excessive use of centrifugation. We are all well aware that centrifugation causes generation of reactive oxygen species, or ROS, and in turn inducing DNA damage. Unfortunately, this DNA damage can lead to lower fertilization rates, reduce embryo progression and quality, and a decrease in pregnancy rates and increase in pregnancy loss. So that led to some in the field developing a more passive type of sperm processing, microfluidic sperm sorting, which is a very passive type of sperm sorting focused mainly on motility. So sperm somewhat select themselves based on their motility, and it results in a population of cells with the highest motility, and no centrifugation is required to select these cells.
Can you hear me?
No. Yes, I can hear you.
Yeah, can you please turn hide the sharing tab on your screen?
Oh, yep. Okay.
Thank you.
So it selects highly motile cells with low levels of DNA fragmentation, lower than that of density gradient centrifugation samples when one sample is split and processed both ways. So should microfluidic sperm sorting replace all density gradient centrifugation? I think it's great in theory, but again, we have this issue with failed fertilization. So this is where the device that we got interested in comes in. So it was the Zymot device made by DX Now. For those aren't familiar, you place liquefied semen in the inlet valve, 850 microliters, then drop media over the membrane, and that allows highly motile sperm to swim up through a polycarbonate membrane that has 8-micron pores. Once given time, the sample is then collected through the outlet port. So again, liquefied semen loaded into the device, put in the incubator. About 25 to 30 minutes, up to an hour later, you then collect the sample out of the outlet port. So obviously there's very little hands-on time for this procedure. It's quite easy to do. Unfortunately, there was no evidence or support for using it with conventional IVF insemination. So from speaking with the company, we know that it results in great sperm with great motility, but low fertilization. So this is some of the research we did in our clinic, looking at what might be going on here. So we repeated the samples looking at progressive motility. So we had semen samples that we split in half. Half was processed using density gradients, the other half processed using Zymot. So the Zymot's green, the density gradient's blue. And what you can see is that motility looks really good. That Zymot edges out density gradient a little bit other than at 24 hours. So that didn't make sense that fertilization wasn't going well with such a great motile sample. So the next thing we looked at was percentage of hyperactivated cells. So this is the spontaneous or the control. And again, blue is density gradient centrifugation and green is Zymot. And what we can see is that the density gradient samples greatly outpace the Zymot. So we can see that the Zymot kind of gets worse over time, especially in that key time that fertilization should be happening with eggs. And it's falling below the 20% that we would like to see to go with conventional insemination. So at all times was it below that recommendation and cutoff for using that sperm sample for conventional IVF. This is the IVOS1 output from those samples. On the left, we can see that you can see that there's quite a bit of a high percentage of hyperactivated sperm. And on the right, you can see that there is a very low percentage. So even by eye, without counting it, you can see that there is a hyperactivation difference between samples processed with density gradients versus those processed with Zymot. So this brought us to brainstorming. Well, what is likely the issue? Why aren't these cells hyperactivated if the motility is so good? The morphology looks fantastic. The DNA fragmentation is low. So what we realized, it's likely a diffusion factor of decapacitation factors from the seminal plasma moving through the device as you draw the sample from the outlet valve. So our idea on this was to do one quick centrifugation spin after the sample is removed from the device to remove any remaining decapacitation decapacitation factors from the seminal plasma. So that's what we did. we added this short spin step. And lo and behold, this is the spontaneous HA max sample at the percentage of hyperactivated cells. And you can see that this restored the hyperactivation in these samples in the output. So most samples are falling above that, 40%. We would like to see upwards of 50%. So again, in that key time window of egg fertilization, we're seeing a good percentage of hyperactivated cells restored by doing this small spin. When working with DX now, they also did an internal study looking at DNA fragmentation of samples, having added this very small spin at the end. And what they found was it didn't induce any extra DNA damage than not doing the spin after the Zymont device. And that's likely because ROS is really generated by, immature cells, round cells, leukocytes, kind of all the extra portions of raw semen in that initial spin. Whereas the sample that you're doing a very short spin on Zymont, all the extra things that have induced ROS have already been removed from the sample for that spin time. So we're able to successfully modify the protocol for using the Zymont to now use it for conventional insemination. And now this is the instructions that come with the Zymont. You can see if you're using it for ICSI or IUI, it's okay to go ahead with the sample straight out of the device. And the idea with the IUI is that the sperm cells will be separated from the decapacitation factors within the uterus. And that for the IVF samples or conventional IVF, you should do a 5-minute spin at 300 Gs to remove any remaining decapacitation factors. So that brings me to the end of my talk, and I'm just wondering if I have sold you on hyperactivation. Clearly, there are some downsides to performing hyperactivation assays in your lab. First of all, it is quite time consuming. The solution for HMX is made up daily. You have to measure out all the amounts in advance. You have to have an IVOS or an equivalent CASA that has the capability to read hyperactivation, as well as all the training that comes with that. So there is some infrastructure and some training and time that you need in order to add this to your semen analysis. There are no strong prospective studies looking at its value at this time, and there are no updated studies. So most of the studies I've talked about tonight, some are from the 90s, some from the mid 2000s. We need some good new prospective studies or randomizing patients into some interesting studies to get a true picture of how helpful this assay is. So yeah, just in general, more research needed, maybe something I will work on in the future. Because we do feel like it is an essential part of maintaining very low failed IVF rates in our clinic. And we feel very comfortable in our clinic offering conventional IVF insemination to the correct population of patients. We have lots of embryologists that have moved into our area after working in other clinics, and they felt very strongly that if it was so many years of unexplained infertility, they should go to ICSI. If advanced maternal age, they should go to ICSI. If a low oocyte yield, they should go to ICSI. And we don't feel that way in our clinic. Those aren't reasons for us to go to ICSI over conventional insemination. And once people have seen it work a number of times with conventional insemination for these patients, they start to trust and understand our process as well. But it can make embryologists who are used to the ICSI for all or ICSI for most approach very nervous when we first start. And I want to thank my team. And not pictured here is Sabrina Flaccari. She was an honor student that did the Zymont hands-on research project. She did a great job, and she just accepted a job running clinical research for the Heart Center in Toronto yesterday. So sadly, she will not be joining us in the IVF lab, but she is continuing with clinical research. with that, I can stop sharing my screen.